Okay, so last session, and slightly different, I'm going to talk a little bit about some of the things we have done looking at epidemiology in the myeloproliferative neoplasms. So we got into this some time ago when a question was arose, the usual question, what's the cause? What's the cause? The same question as every patient asks, why have I got this? And for various reasons, I ended up working with an epidemiologist, a person who particularly looks at the causes of whatever the thing of interest is. And as soon as we started doing this, the first thing we had to do really was look at what the incidence of these things are. And that was quite interesting because what you have to do is look at all of the literature and then do an analysis of that. And we did that and came up with figures of the incidence from all the published work. So we started out with that the incidence of, this is new cases of polycythemia vera, is 0.48 per 100,000 of the population. To make that real for ourselves, and it's where we sort of extrapolated it up to, now you may have realised by now I'm very schizophrenic about my nationality. So we started out with Northern Ireland, which has a population of about 1.8 million. So that would work out about 15 new cases per year in Northern Ireland with PV. And then we did it for Ireland as well, because we are this very schizophrenic people. I know I have both a British and an Irish passport because of Brexit. So, you know, we can't make up our mind what country we're living in. So we did the whole of Ireland, and it has a population of about 6 million. And so that works out that you would have about 15 new cases of PV a year in Northern Ireland, 39 in the whole of Ireland, ET 19 and 47, and primary myelofibrosis 8 per year and 22 for the whole of Ireland. So these are rare disorders. Prevalence, which is which will of course be much higher because people have these disorders for many, many years. So prevalence is the number of cases in the population. It's actually impossible to do from the literature because there's just not enough information there. So that was all right as a start, but we wanted to look further at who gets myeloproliferative neoplasms. There's some things that everybody knows. PV is more common in males than females. ET is more common in females. Similar numbers with myelofibrosis. Certainly these are disorders which occur more frequently with increasing age, but they do occur in young people, of course. And there were some genetic factors known. There's some evidence that Ashkenazi Jews are at higher risk, and there's some inheritance factors, as we know, which is a different bit of scientific research. But inheritance certainly does not explain why most people get myeloproliferative neoplasms. So you're left with, I quite like this picture, you know, it's looking for the needle in the haystack. What's the cause? So how do we take this forward? So with my epidemiology friend who knows how to do these things, the first step was to survey the literature, to look comprehensively at what had actually been done before. So we did that, and we ended up with 9,156 titles and abstracts to look at. So that was a lot of sifting down. But when it came down to it, there were actually only 19 studies which had been done looking at the epidemiology of myeloproliferative neoplasms of various sorts. These studies, some of them are very old, and it's fair to say that they are all very small. But we looked and analysed all of the information that was available in the published information. Some things came out. Family history appears from time to time, so you keep getting this, how much is the inheritance, but that's a different story. Jewish descent, there's clearly a preponderance in Ashkenazi Jews, which is seen in the literature. Certain autoimmune conditions were mentioned from time to time, and certain other occupations So we looked further. The studies come in two types, and they are what are called cohort studies and case control studies. So a cohort study is when somebody has a big database of people who do something, like funeral service workers. Somebody has a database of large numbers of funeral service workers, and you look at the database and see, are there more cases of myeloproliferative disorders of various types compared to what you would expect in the population in general. So, and the other type of study, which I'll come back to, are case control, where you go out and you get 20 people with ET and get 20 controls and look to see, are there any differences between the cases and the controls. So in the published literature, there is some evidence in certain cohorts that there are certain occupations where there may be an increased incidence of myeloproliferative disorders. But remember, these are very small numbers of disorders. If you have 2 cases in the cohort and 1 in the equivalent population, it comes out as significant. So they're really tiny numbers. But commercial pressmen, petroleum refinery workers, funeral service workers, rural sector jobs, agricultural workers, poultry workers, shoemakers and those with electrical devices, cooks, waiters, clerks, hairdressers, nurses, farmers, electricians and photographers. These are all people that there are at least tiny studies looking at their incidence of myeloproliferative neoplasms. Also, certain medical conditions seem to appear more in some of these studies, and certainly some autoimmune conditions, which is what somebody was asking about yesterday. There seems to be something that autoimmune conditions appear more frequently. But there are also things like this, tiny studies showing that groups of patients with adenoma of the parathyroid gland had an increased risk of getting PV, but tiny numbers of patients. So also, other things, using hair dye for more than 10 years is associated. So again, we're looking all the time at what chemicals the people are exposed to. Is there anything else? Actually, when you look at other studies, there was no association between hair dye, solvents. We're always looking at solvents and things like that. So there's a wealth of information out there, but actually, is it a wealth of information? It's actually very little. So we thought, what is needed is to look at this much further. Because you can look at 50 people and throw out hair dyes, but what does it mean? As soon as we tried to do this, it produced a large number of questions as to how you go about this and what's the best way to do it. So the first thing that we had to decide, which was a no-brainer, that what we wanted to do is a case control study. You weren't going to do a cohort study because you've got to have a big cohort with a large database. And what does that mean? So the first bit was this is going to be a case control study. With a case control study, what you do is you have a group of patients with MPN and a group of controls. And I'll come to you in a minute because the first question is how you get the controls. And then you give the same questionnaires to both and then see what factors come out. And the idea is that in the NPNs, you may see that more of them have been exposed to something than in the controls, but you're doing a comparison. So with the epidemiology advice, it's very clear you've got to do a case control study. But we then ended up with a number of different questions that you just didn't know what was the best way to do it. So we had to set up a pilot to try and organise this, and it's actually the pilot I'm going to talk to you about. So the questions that come up, how do you get people involved? Is it better to give them a bribe, a £10 gift for participating? Is it better to give them an MPN voice trolley token or an MPN voice pen? Or maybe if you just do that anyway because you're promoting MPN voice. So there are a whole lot of things as to how to get people involved. How many people would take part? If you ask people, will they actually take part? If you remind them, does that help? What ways are the best way to do this? What we specifically wanted to do was to develop a questionnaire that we could do this all once we recruited people, put somebody on the telephone to go through the whole information. And there are people out there called occupational epidemiologists who have spent their whole life developing these questionnaires, and the idea is that you go through what people did and then you ask more questions and you end up with all of the data about their exposures, etc., both since the diagnosis was made but particularly pre their diagnosis. And then you want to do the same with your controls. So there were questionnaires there known as FinGem and OCIDES, but they can be adapted a little bit to the particular MPN questions to bring in the things that were suggested by previous work may be of importance. You had to look at that. So we needed to develop a telephone questionnaire, and with that the suitability of questions investigating occupation, residence and lifestyle. And with that, the use of these occupational exposure assessment tools. So that all goes together. You have to actually work out how to do it. The other thing we wanted to do was, if we were doing this, is doing quality of life at the same time. You're going to talk to lots of people with MPN. This is a good time to find out to do the MSF10 on them. And what we thought would be a very good idea to do, which nobody else has done, is to do the same thing with the controls. That was what we thought we'd do. And the final thing you want to evaluate, because if you're going to do any research and collect hundreds of patients up, everybody wants, can you get a DNA sample at the same time so that you can then do further research on that. Because this is sort of where, you know, if you're looking at this, you want to see, can you get, if you're going to look at 200 MPN patients, can you get samples on them? So we actually looked at that as well. As to what were the best and would people do this, and what were the best and easiest ways to do this. And this even totally involved Leslie and I pricking our own fingers and sending the samples in first in the post to see would that actually work. So with all of this, we then set up and got funding from MPN Voice, which was absolutely crucial, to do a pilot study. And this was the Mosaic study. It's myeloproliferative neoplasms, an in-depth case control study. So that's what Mosaic is. This was to be an exploratory case control study. The idea was we would look at 100 patients with MPN. That was the aim, to recruit 100 patients and 200 controls. And we were going to look at two different ways of recruiting the controls to see which was the most successful. Recruiting controls is always the issue. You know, the patients all want to do it, but how do you get the controls? So the two classical ways to do this, one is to ask the patients, can they recruit non-blood relatives or friends? So the spouse can do it, but not the child, because they won't, the non-blood relatives, they don't have the same genetic background, but they will have lived in the same environment, etc. And the other way, which in ways is better, is to go to the local GPs or the local hospital and just sort of recruit people off the street, if you can do it. The problem about that is, as you say, will anybody actually do it? So the way you look at this is to go to the GPs, keep registries, and they can go and ask people, would they volunteer as a control? What we actually wanted to evaluate was recruitment procedures and response rates, the development of the telephone-administered questionnaire, assessing all the factors, feasibility of collection and quality of life. So we did this. This was a pilot case control study. It was done in Belfast and Southampton, so in two big MPN centres. These were the two doctors who got into it and thought of it in the first place. We actually recruited 106 patients. That is, by the time we realised that 106 people, you know, that we were over the 100, there were 106 people had already come in. 37 PV, 55 ET, and 14 primary myelofibrosis. And we actually recruited 127 controls. So you immediately see, you know, we wanted 200 controls. We actually were 127 controls is actually very good. But huge difference, 46 from general practice, whereas 81 non-blood friend controls. So you get the first answer immediately. If you're doing a bigger study and you're trying to get your controls from this method, you're going to struggle. Whereas the non-relative friends, and that may not be the perfect controls, but at least you'll get a good selection of them. What about the results then? What did we find out? Well, the first thing that we found out, which is actually quite important if you're setting up a larger study, is incentives do not affect participation. There is no point in giving people a bribe. They're either going to do it or not. That's actually quite important, because if you're setting up a study, even something like a £10 check actually costs quite a lot, because you have a whole administrative thing to generate this and put it through the system, and people take the checks and don't cash them, it's all lost, and all sorts of things like that. So there's no point in doing that. So it's a waste of time. They're either going to do it or not. You can give them the MPN voice anyway, MPN voice pen anyway, just to raise the profile, but you don't need to try that. The other one that was quite interesting, one of the things we did was, the way we actually did this was got patients in the clinic and gave them a pack offering the study and with a phone number to phone if you would be happy to do it. And if they then phoned the number, then we would consent them, and they would, or we actually asked them to send in the consent form if they were happy to do it, and then somebody contacted them by phone. So what about the people who you hand this out to and you never hear anything more from? Well, you can't hassle them every 2 weeks. You can't keep back onto them. But what we did have is that you could have one attempt at asking them further, and that went through ethics and was approved. But we actually randomised between, they would be followed up with a letter or a phone call. And purely randomised, it was pure lottery which they got. And it was very clear that a phone call was much better than a letter. That if somebody had been given this in the clinic and you rang them up once, you can't keep doing it, just once, and said, what about this? They were much more likely to do it. And actually that was, because I did a lot of the phone calls, that was, you could see that very quickly. Oh, I meant to do that, I'd forgotten, yes, I'll do that. And occasionally you got people who said, no, I'm not doing it, I'm too busy. But you actually got it from the phone call very quickly. You could then say, okay, fine. And the other bit that was very interesting, all participants, both patients and controls, consented to provide at least one biological specimen. And that's quite important, because it's a great way of then collecting up a collection of material for further research. What about the quality of life? What did we find out from that? So these are all the symptoms that you're all very aware of, and this is the MPSF-10. And what we did is this was administered to both the patients and the controls. And we found out, and this has been published separately, that the symptomatology in the patients was much more than the controls. And I think this is actually quite important, because nobody's actually done this before. So the way this spider plot works is the further out you are, the higher the symptoms were scored. Red is the patients and blue is the controls. So you can see here fatigue, because certainly people like me have a problem with everybody complaining of fatigue, because everybody's got fatigue. But you can see here that the MPN patients, it's much more than in the controls. And these, you see the controls, I mean, they were the sort of same age, sex matched controls. They were fairly good matched. And you can see that right through, that the controls have much, will score themselves much less on this than the patients. You can also split it up and see differences between the different diseases. Again, perhaps not unexpectedly, myelofibrosis had the highest scoring of symptoms. And we also were able to compare this with Ruben Messa's database, which has several thousand patients in it. And our group had similar patterns of symptomatology than bigger cohorts. So, looking at it a little bit more, because I do have actually some results of the study. It wasn't actually, the idea of this was to find out ways how to run a further study, but when we did it, we actually had enough to analyse and get some results out of it. And that was not the primary purpose of the study. We didn't think it was going to be big enough to do that, but actually we did get some significant results out of it. So again, just to compare, you can see the controls and the cases. There's really no differences in things like age, gender, etc. It is true to say, given that where this was done, it's very predominantly a Caucasian population, but that is an issue when we talk about a bigger study that obviously you would want to get that further, but you're not going to get too much further than that if you're certainly in Belfast. So what did we find? Well, there were lots of different things that were looked at, that some of which came out, and I'm going to draw attention to the things that came out with a significant difference. So first of all, social class. Myeloproliferative neoplasms are significantly more compared to the controls in lower social classes. Sorry. The other thing that came out significantly is patients with myeloproliferative patients were more likely when they were children to have been had more than one child per bedroom. In other words, to be brought up in households where there were more than one child per bedroom. That may be linked, of course, to social class. You know, if there's 2-3 children per bedroom, that may be linked. Other things, and this is looking at the lifestyle factors, so perhaps not unexpectedly, and as in previous work, myeloproliferative disorders people with myeloproliferative disorders are more likely to have been smokers or ex-smokers than the controls. And perhaps cheerily, patients with myeloproliferative disorders are less likely to have had alcohol is possibly a good thing from the myeloproliferative disorders, is the best way to put it. Which is, yeah. The other thing is looking at environmental factors, and again, there's lots and lots of questions about this because of all these studies that have been done before, and lots of things about exposures. From the point of view of what came out as significant in the control, painting in the house is less likely to occur in patients with myeloproliferative neoplasms than in the controls. So you might have expected the other way around. People who were doing a lot of exposure to, I mean painting walls, I don't mean painting pictures, I mean painting walls, exposure to various chemicals was actually less likely. So lots of data, but just to draw attention to the main things, more common in myeloproliferative patients than controls, growing up in a house with one or more children per bedroom, higher household density, smoking, and the final one, which I think we need to look at more, is having had more CT scans, and this is certainly more common. But this is an issue for taking forward because it's dissecting out how many of the CT scans, when they occurred, whether they were in the lead up to the diagnosis or much earlier, because perhaps not unexpectedly, patients with myelofibrosis had a lot more CT scans. What we could say in our study definitely that we didn't get associated was blood donation, and that was an issue from a study before. There was some suggestion that being a previous blood donor might be important. Hair dye, because I like the idea of hair dye, and autoimmune disease. So that was the Mosaic study. This has been written up and published. A number of collaborators, myself and Andrew Duncan, Glenn was formerly Titchmarsh, now James. This was his PhD project, and he has written a lot of this up, and a number of other collaborators who've worked in various aspects of this, including the occupational epidemiologist and, of course, Ruben Mesa. So where do we go from here? We know what we need to do. We know how to do it now, which is what this is. But we need to do a bigger study, and that's what we've been planning. We would like to do at least 1,000 people study, and with ideally 2,000 controls. We have spent a lot of time putting in applications to try to get funding for this. Unfortunately, our cancer charities seem to think that this is not a serious enough disease compared to some of the cancers that they deal with. So we have been putting together money. MPN Voice have promised a lot of money. We've got some from the Northern Ireland Leukemia Fund. We've an enabling grant from a Northern Ireland Society, and we've got about half the money. And we've then, at the moment, asked Novartis, could they give us the other after 3 years? And the latest update is that has gone to global, and they think well of it, and we're just waiting to hear. If we could get that money, we could start in the morning and have this done in 3 years. We would also have very quickly a larger study, because because we can set the whole thing up, and our colleagues in Australia and the US will then do it and add in. And then the idea is the more we get, we have a huge pool of data, including our original 200, because that can roll over into this study as well. And we might be able to look at other things like the Dutch joining in and things like that. That would require translation. But, you know, the potential is there just as soon as we get the money to start to do what I would contend would be the proper epidemiological study for myeloproliferative neoplasms. Thank you.